Assalamu alaikum. Good afternoon, everyone. Today we'll continue our cardiac surgery academic activity with two lecture basic of cardiopulmonary bypass by Dr. Sultan Al-Amr and cardiopulmonary bypass pitfalls and troubleshooting by Dr. Khalif Al-Anizi. I would like to welcome our consultant guest, Dr. Bakir. He's associate professor and consultant adult cardiac surgery in King Saud University Medical City. Welcome, Dr. Bakir.
السلام عليكم أهلا وسهلا.
Assalamu alaikum. So, Dr. Sultan, you can prepare your slide. We're starting at 1:05, inshallah. Dr. Sultan, you can start now.
السلام عليكم.
السلام ورحمة الله. We can hear you now, Sultan.
اوكي الله يعطيك العافية. بسم الله الرحمن الرحيم. I'm Sultan Amro, cardiac surgery resident at King Khalid University, King Saud University, Medical City. Today our talk is about basics of cardiopulmonary bypass. Please, if you have any comment, feel free to interrupt me anytime. So my lecture will be complemented by next talk by Dr. Khalifa. Inshallah, we'll go through a brief introduction about cardiopulmonary bypass. Then talking about the concept of cardiopulmonary bypass in three main headlines: circulation, gas exchanging, and then safety and support. Finally, we'll go through some points about establishing cardiopulmonary bypass circuit. The first successful attempt of using the heart-lung machine was by Dr. John Gibbon in 1953 on an 18-years-old Cecilia Bavoli, who underwent an arterial septal defect that was repaired with continuous suturing while the patient was completely supported by the heart-lung machine for around 26 minutes. A successful initiation of stable circulation via cardiopulmonary bypass is fundamental for most cardiac procedures, especially intracardiac, as it provides less ischemic operation and with better exposure and more safe dealing with emergencies. There is two main problems associated with cardiopulmonary bypass as a result of exposing blood to a foreign non-endothelial cell surface. So it's responsible for triggering an inflammatory response that usually initiate a powerful thrombogenic stimulus, which may mandate the need of anticoagulation for using cardiopulmonary bypass. So basic cardiopulmonary bypass circuit consists of venous lines, reservoir, pump, then oxygenator with heat exchanger and filter, then back to the patient through arterial line. The component of circulation through a cardiopulmonary bypass machine are venous return, venous reservoir, arterial cannula or arterial line, and pump plus tubing and connectors in between. Usually, venous return is drained from the patient either by gravity or siphonic drainage to a reservoir that's placed around 40 to 70 centimeters below the level of the heart. So sometimes assisted venous drainage is needed, which is a negative pressure drainage that's achieved by using a pump system or regulated vacuum to venous reservoir. And it permits the use of smaller cannula size, but it increased the risk of aspiration of air and hemolysis. The amount of drainage is determined by three main things. The first is central venous pressure. Second is the height differential between the heart and reservoir. Third one is the resistance within the system, the cannula, tubing, and connectors. Central venous pressure itself determined by intravascular volume and venous compliance, which can be manipulated or controlled by using medication. So line shattering caused by a venous or atrial wall collapsing against cannular intake openings, which reflect inadequate blood volume or excessive siphonage pressure. Venous cannulas in usual are made of flexible plastic that stiffened with wire reinforcement. The cannula tip is thin, rigid, either plastic or metal, and either straight or angled. Typically inserted through a purse string guarded incision. There are three basic approaches for central venous cannulation. First one is bicable, separate cannulas, each one in SVC and the other one in IVC. Second approach is single atrial. The cannula go through the right atrial appendage or lateral atrial wall. The third one is cavoatrial, which known as two-stage cannula. Femoral or iliac veins cannulation, considered as alternative approaches of cannulation that's approached by either open or percutaneous technique. Usually employed in emergency situation or with patient who's undergoing thoracotomy surgical approach, and in circulatory unstable patient prior to induction of anesthesia. Usually TE can be particularly helpful in assuring a proper placement of the cannula. So these are the different venous cannula. Here we have the atrial single cannula, and this one is the two-stage cannula. This is bicaval, this is curved, and this is angled tip cannulas. And this one is the long femoral multi-stage cannulas. Selection of cannula size is based on patient size or body surface area and patient weight and vessel size, cannulated vessels, targeted cannulated vessel size. Also is based on desired flow through the cardiopulmonary bypass and the index of catheter flow. So for average adult patient, a 30 French SVC and 34 French IVC cannula, or a single 42 French cavoatrial catheter provides excellent venous drain. So volume reservoir during cardiopulmonary bypass served as a high capacitance receiving chamber for venous return, and it also facilitates gravity drainage and considers as a venous bubble trapper and provide access for drug, fluids, or blood to be added to the circuit or perfusate. And also it is the largest storage capacity for perfusion system. So around as much as 1 to 3 liter of blood may be translocated from the patient to circuit while on full bypass. This also can provide a few seconds or several seconds for of reaction time if any emergency or unexpected venous return decrease or interruption. There is two types of reservoirs are available, the rigid and collapsible. The advantage of rigid canisters is first one is the volume measurement with larger capacity. Second one permits vacuum assisted venous drainage can be added to it, and the measurement or the management of venous air can be done through the reservoir, the rigid reservoir. But the collapsible bag eliminates blood gas interference, and it's a closed system, so it eliminates blood gas interference and reduce the risk of pumping massive air. Now we'll move to arterial line or arterial part of the cardiopulmonary bypass. The tip of the arterial cannula is usually it is the narrowest part of the perfusion system, which may provide a high pressure differential and turbulence flow. Arterial catheters are rated by performance index, which take into consideration the external diameter, the flow, and pressure differential. Pressure differences that exceed 100 millimeter mercury can cause excessive hemolysis and protein denaturation. There is different types of arterial cannulas. The first, or let's mention, is end-hole aortic cannula, the side port cannula, and dual-stream aortic perfusion catheter. The fourth one is aortic cannula with mesh filter. Choosing cannula and site of insertion is influenced by the plant operation itself and distribution of atherosclerotic disease. Cannulation for arterial line, there's three common approaches. The traditional one is distal ascending aorta cannulation, and it is most common. It is the traditional one is distal ascending aorta cannulation. It's the most common cannulation site. The cannula is placed within one or two concentric purse string sutures, then snared. So reducing the systemic pressure during cannula insertion may reduce the risk of dissection. So many surgeons choose to transiently reduce the systemic pressure below 100 millimeter mercury. And proper cannulation placement is confirmed by observation of pulsatile bleeding into the cannula pulsatile pressure in aortic line monitor, and equivalent pressure in the line and radial artery. The other alternative approach for arterial cannulation is the femoral or iliac arteries cannulation. It's the first alternative to aortic cannulation and the primary choice for rapid initiation of bypass as an emergency situation, as in severe bleeding, cardiac arrest, acute intraoperative dissection, or severe shock, or in minimal invasive surgeries, or some patient who's going for reoperation. Common insertion approaches is either percutaneous cannulation or open Seldinger technique, which use a wire reinforced insertion of a cannula through a purse string in the femoral or iliac vessels by direct cut down. The risk of ischemic complication of the distal leg may be reduced by a small Y perfusion catheter or side graft that anastomosed to the artery. Retrograde arterial dissection is the most serious complication of femoral or iliac arterial cannulation. It's not always necessary to repair it unless it progresses proximally to involve the aortic root. Advantage of axillary subclavian artery cannulation. It's the freedom from atherosclerosis, antegrade flow into the arch vessels. Limb is usually protected by collateral flow, and it's usually preferred over femoral in patient with aortic dissection due to the dangers of retrograde perfusion in these patients. Two types of pumps are available. The most heart-lung machines use the two types in one circle for different. Two pumps from different type of pumps in the same circle. The first one is centrifugal pump, and the second one is roller pump. Centrifugal pump is a veined impeller which, when rotate rapidly, that propel blood by centrifugal force. Forward flow in this pump is affected by rotation speed and afterload of arterial line. So an arterial flow meter is required in this using this type of pump, and it produces pulseless blood flow. The second type is a roller pump that consists of a length of polyvinyl or silicone or latex tubing which is compressed by two rollers. Here's the tube, and these the two rollers compressing the tube, and it's 180 degrees apart inside a circular raceway. So forward flow is generated by roller compression. Increase the compression, increase the flow, but in the same time is increase the risk of rupture. So flow rate is depending on the tube diameter, rotation rate, degree of occlusion or compression, the length of compression raceway, and it usually produce a sine wave pulse around 5 millimeter mercury. The various components of heart-lung machine are connected by polyvinyl tubing and floated polycarbonate connectors. So the polyvinyl tubing is flexible, compatible with blood, non-toxic, smooth and transparent, resistant to kinking and collapse, and can be heat sterilized. Usually a half or 5/8 inches internal diameter size of tube is used for most adult patients. Heparin coated tubing doesn't reduce the inflammatory response to cardiopulmonary bypass, and the evidence for clinical benefit is not convincing. So now we'll move to the gas exchanging or estimated lungs of the machine. Oxygenator systems contains one of two types of oxygenators. So there is two types of oxygenators, membrane or bubble oxygenators, and including an oxygenator systems. So oxygenator gas supply system consists of the oxygenator and flow regulator, flow meter, gas blender, and oxygen analyzer, gas filter, and moisture trap. Usually it comes in one compacted unit that combines the venous reservoir and heat exchanger and oxygenator, especially if using the hollow fiber membrane oxygenator. Blood gases must be monitored. Arterial PCO2 is controlled by gas flow rate through the gas blender, and PO2 is controlled by FiO2. Nowadays, almost all cardiopulmonary bypass machine using membrane oxygenator. It is a thin membrane, microporous, polypropylene or silicone rubber between the gas and blood. The concept of membrane oxygenator, that blood is spread as a thin film over a large area, and plasma-filled pores prevent gas embolization, but it's allow or facilitate transfer of both oxygen and carbon dioxide. Oxygen diffusion needs a higher differential gas pressure, but carbon dioxide diffused with the small differential gas pressure. There is a different membrane design used in membrane oxygenators. So a hollow fiber sheaves or spiral coil silicone membrane. Hollow fiber membrane is associated with a risk of leakage, of protein leakage after 8 to 12 hours of use. So usually spiral coil silicone membrane is preferred for the prolonged perfusion, like in that for days, like in ECMOs. Bubble oxygenators can be used for short-term bypass as because of the low cost and efficiency. The concept of bubble oxygenator, that oxygen is infused through a diffusion plate that produces 1,000 of small oxygen bubbles within the blood. So the gas exchange occur across the thin film at the blood gas interference around each bubble. So carbon dioxide diffuse into the bubble and oxygen diffuse outward into the blood. Bubble oxygenators cause progressive injury to blood elements and entrain more gaseous microemboli. Let's move to our fourth part of the lecture, the safety and support, while we'll talk about different safety and machine supportive devices. So we'll start with the filters and bubble trappers. Aside from technical errors, the cardiotomy reservoir is the largest source of gaseous emboli in membrane oxygenator perfusion system. So using a membrane oxygenator and cardiotomy reservoir filter, that minimize and washing blood aspirated from the field. This table outlines the common sources of microemboli, and is categorized into gas, foreign emboli, or blood product microemboli. The types of microfilters, there is two types, either screen filter or depth filters. Screen filters is woven polyester or nylon thread that filters by interception, and the size of the pores is different, and different size and configuration. So as pore size decrease, the resistance increase through the filter, and it block most air emboli. Depth filter it's a packed filter or porous foam that removed microemboli by impaction and absorption. The brain received 14% of cardiac output and is the most sensitive organ for microembolic injuries. There's some strategies to selectively reduce microembolism to the brain. It's either by reducing PCO2 to cause cerebral vasoconstriction, hypothermia, and placing aortic cannula downstream the cerebral vessels. So surgically induced emboli are more likely to cause post-operative neurological defects than perfusion microemboli. Because gases are more soluble in cold blood, so rapid rewarming of cold blood may cause the formation of bubble emboli. So the temperature gradient between the body and perfusion circuit remains, or should be usually remains, within 10 degrees to prevent bubble emboli. Most membrane oxygenator units Most membrane oxygenator units incorporate a heat exchanger. So separate heat exchanger are needed for cardioplegia system. The cardiotomy, sorry, it's cardiotomy. The cardiotomy reservoir is a rigid shield that collect field aspirated blood from deforming for deforming and filtration and storage, then directed again to perfusate. So a roller pump or vacuum is applied to generate negative pressure suction. And it is the major source, as we mentioned, of hemolysis, platelet injury, and loss, and particular gaseous microemboli. So high suction volumes and admixture of air are particularly destructive of platelet and red cells. So field suctioned blood can be diluted with saline and then reconcentrated to return only backed red cells to perfusate. There is a two types of centrifugal cell washer. The intermittent centrifusions and continuous centrifugation. So the intermittent removes air, thrombin, and many microemboli, and discarding plasma. The continuous, in additive to the previous one, it's also remove fat and it's and activated leukocytes. Bronchial blood flow average approximately 150 ml per minute. So a multi-hole soft tip catheter is inserted as a vent to minimize blood back into the field and to improve the exposure. It's usually inserted through the junction, it's either the junction of the right superior pulmonary vein and left atrium, or left atrial appendage, or retrograde across aortic valve, or left ventricular apex. Cardioplegia line inserted into the aortic root is usually used as a vent or root venting if cardioplegia is not administrated. Cardioplegia system, the cardioplegic solution with usually with either crystalloid or blood base are infused into the aortic root proximal to the aortic cross clamp, or retrograde into the coronary sinus to arrest the heart in diastole. Delivered usually the cardioplegia or cardioplegic solution delivered through a roller pump in a separate system that include cardioplegia reservoir and heat exchanger, bubble trapper with microfilter. So antegrade cardioplegia usually administered through a small cannula in the aortic root. The cannula is direct or cannulas that directly into the coronary ostia. Retrograde cardioplegia is administered through a cuff catheter inserted into coronary sinus. The placement is verified by either palpation, TEE, blood color, or pressure waveform. The complications include rupture or perforation of coronary sinus. For hemoconcentration or hemoconcentrators is semi-permeable membranes that transfer water and electrolytes out of the blood compartment, is connected either anywhere in the circuit, is either venous or arterial, but required high pressure in blood compartment to effectively remove fluid. It's conserve platelet and most plasma protein and allow greater control of potassium. So many monitors or alarm systems are applied to cardiopulmonary bypass system. The first one is arterial line pressure. That is between pump and arterial line filter that monitor the pressure continuously, and should be the pressure should be higher than radial arterial pressure because of the resistance of the filter and the cannula. Usually connected to an audible alarms or pump switch that if very high exceed the limits to stop the pump. An arterial line flow meter is essential for centrifugal pump systems. In lines oxygen flow and pressure gradient across membrane oxygenator should be continuously monitored, as any disturbance could be an early indication of oxygenator failure. So inline devices placed within the venous line continuously measure blood gases or hemoglobin and hematocrit or some electrolytes. Other additional safety alarms that is low level sensor on the venous reservoir, bubble detectors on arterial lines. Our final part of our talk today is about conduction or starting a cardiopulmonary bypass. So assembly of a cardiopulmonary bypass, there is a dry and wet or priming assembly. Dry assembly takes about 10 to 15 minutes, can be kept in standby for around 7 days. But if it's primed with fluid, that will take also 15 minutes. That should be used within 8 hours to prevent malfunction of oxygenator. The usual adult circuit requires around 1.5 to 2 liters of balanced electrolyte solution like ringer lactate. So this in the average size adult, the priming volume represent approximately 30 to 35% of patient's blood volume. So addition of 12.5 to 50 grams of mannitol that simulate the diuresis and may minimize post-operative renal dysfunction. Hematocrit by priming reduced to about 2/3 of preoperative value. This is a hemodilution effect. So that's also result in reduced viscosity, which is good for the pump, and but reduces oxygen carrying capacity. So most perfusates have hematocrit between 20 to 25 when used with moderate hypothermia between 25 to 32. And to minimize hemodilution and achieve an acceptable hematocrit, there is many strategies used. Is either autologous blood prime technique or banked blood may be added to prime volume, especially in smaller patient or in the presence of perioperative anemia. So anticoagulation for and during cardiopulmonary bypass. Before initiation of cardiopulmonary bypass, a 300 to 400 before insertion the arterial or venous cannula, a 300 to 400 units per kg of IV heparin should be administered, and anticoagulation effect of administered heparin measured by about 3 minutes after heparin administration, generally using the ACT. More accepted ACT is more than 400 before initiating cardiopulmonary bypass, although some groups of surgeons recommend 480 is second. So failure to achieve targeted ACT is either inadequate heparin dosage, so heparin can be re-administered with a maximum dose of 500 units per kg, or a low concentration of antithrombin. So after starting and during cardiopulmonary bypass, the ACT should be measured every 30 minutes, and usually one third of initial total heparin bolus required for adequate anticoagulation is given every 1 hour, even if targeted ACT is achieved. Reversal of anticoagulation. 1 milligram of protamine is given for each 100 units of heparin given in the initial bolus dose, but not to exceed 3 milligram per kg. A calcium, 2 milligram of calcium may be administered to attenuate the acute hypotension caused by heparin protamine complex. Cardiotomy suction into the reservoir is discontinued immediately after protamine administration, and reversal of heparin is confirmed by ACT. Heparin rebound is delayed heparin effect because of the release of tissue heparin after protamine is cleared from circulation. So usually it's happened or seen after patient transfer to ICU. For initiation of cardiopulmonary bypass, surgeon, anesthesiologist, and perfusionist, all of them are involved. So as starting cardiopulmonary bypass, after starting the flow, there is 6 observations are critical. The venous drainage should be adequate, and arterial line pressure should be in acceptable range, and adequate arterial blood oxygenation with acceptable systemic arterial and venous pressures, plus the heart is adequately decompressed. After 2 minutes of full stable cardiopulmonary bypass, the lung ventilation can be stopped. Perfusion calling may be started, and aorta may be clamped or can be clamped. So early hypotension that associated with initiation of cardiopulmonary bypass is a result of vasodilution as patient is vasodilatation as patient is first exposed to an artificial surface, particularly the oxygenator. Usually it can be managed by either increase the pump flow or a small dose of vasopressors. As we mentioned, usually blood or crystalloid cardioplegia administered either by antegrade flow. So for antegrade cardioplegia flow, the pressure should be between 60 to 100, and that will induce arrest within 30 to 60 seconds. Retrograde cardioplegia flow is 200 to 40 ml per minute, and the pressure usually or should be between 30 to 50. It's usually 2 to 4 minutes slower arrest induction than antegrade, and maybe incompletely protective for the right ventricle. Physiology of blood flow through the cardiopulmonary bypass. A blood flow rate is basal normal cardiac output is approximately 250 ml per minute, and accepted cardiopulmonary bypass flow index at 35 to 37 temperature with a hematocrit of 25% is 2.4 liter per minute per meter square. So to compensate hemodilution effect on blood oxygen content, increase the flow rate and decrease oxygen consumption. So oxygen consumption is reduced by hypothermia by a factor of 0.5 for every 10 degrees decrease in temperature. And in normal adult, so as the result is in normal adult, adequate flow rate is 1.8. This is flow rate index 1.8 at 30 degree, 1.6 at 25, and 1 liter is acceptable at 18 degrees. Systemic arterial pressure is determined by the flow rate, the blood viscosity, and vascular tone. So even with less than normal flow, cerebral flow is preserved by autoregulation protection as long as the mean arterial pressure is between or above 50 to 60 millimeter mercury. The regulation be the autoregulation. And in older vascularly diseased or hypertensive patient, The mean arterial blood pressure could be maintained between 70 to 80 at 37 degrees. So the advantage of hypothermia during bypass is brain protective, permit perfusion at lower flow and hematocrit, increase the safe duration of circulatory arrest. But disadvantage is that it interferes with enzymes and organ function. So as a result, we'll have aggravated bleeding and increased systemic vascular resistance with delayed cardiac recovery during weaning and increase the risk of cerebral hyperthermia. So management of blood pH during hypothermia. So there is two strategies of managing the pH of the blood during hypothermia, either pH stat and alpha stat. For pH stat is maintain pH stat, you maintain or keep correcting the pH with each temperature to 7.4. So keep it maintained at 7.4. This requires addition of CO2. And this also gives better neurological outcome in pediatric. But alpha state that you allow the pH to increase with hypothermia and blood become alkalotic, but cerebral blood flow is lower, auto-regulated, and coupled to cerebral oxygen demand. So maybe better in adult cardiopulmonary bypass. Monitoring during the bypass, systemic pressure monitoring. We can use radial, brachial, and femoral arterial lines. For systemic central venous pressure, usually a jugular venous catheter is used. Neurophysiology monitoring is controversial, but particularly important in deep hypothermic circulatory arrest. So many devices used for neurophysiology. Some of it is jugular venous bulb temperature and saturation, the near infrared transcranial reflectance spectroscopy, and raw or processed EEG, also transcranial Doppler ultrasound. Temperature monitoring during cardiopulmonary bypass is achieved by, or can be accessed by either bladder or rectal probe, but temperature probe that usually doesn't reflect brain temperature. Esophageal or pulmonary artery temperature is affected usually by local cooling associated with cardioplegia and ice. The jugular venous bulb is the best for estimating brain temperature, but is more difficult to obtain. The nasopharyngeal or tympanic membrane, this is commonly used, and it's usually during rewarming is underestimate the jugular venous bulb temperature by 3 to 5 degrees. So adequacy of perfusion can be monitored by either mixed venous oxygen saturation that assess the relationship between oxygen delivery and consumption, Less than 60% indicate adequate oxygen delivery. Higher levels of mixed venous saturation does not assure adequate oxygen delivery to all vascular bed. Also, metabolic acidosis or higher lactate or increasing in lactic acid level may indicate inadequate perfusion. And urine production is reassuring during cardiopulmonary bypass. Otherwise, decrease in urine output should be investigated. Finally, a weaning from cardiopulmonary bypass. So before stopping the bypass machine, patient should be rewarmed to 34 to reach 34 to 36 degrees. Lungs are re-expanded and ventilated. Monitoring of cardiac rhythm, hematocrit, blood gases, and plasma electrolytes. TE is recommended for any opened heart procedures to detect trapped air before or adequate de-airing before stop or decannulation. Cable catheters are adjusted to ensure unobstructed venous return. The aortic root vent is placed on gentle suction to remove any pushed air in the aortic root. As in starting the bypass, also in weaning the bypass should be should be done, or surgeon and anesthetist and perfusionist should be, all of them are involved. Venous line is gradually occluded. The pump input is simultaneously reduced. Close monitoring of physiologic parameters of the patient, and volume is added or removed to produce physiologic ranges of systemic blood pressure, arterial and venous. Pulse oximetry saturation near 100% with tidal volume, end-tidal PCO2, end-tidal CO2 more than 25, and mixed venous saturation above 65% is satisfactory for weaning. All catheters and cannulas are removed. Protamine is given to reverse heparin. Thank you. Any question?
Sultan,
Anna.
thank you for the nice presentation. Could you explain pH stat, alpha stat again?
95 pages. It is 95 pages.
اللي أنا فهمته إنه ال pH stat or alpha stat during rewarming of blood, the pH of the blood is increasing. So it's either you have to follow let's start with pH stat. pH stat, that means we fix the pH at 7.4. That with each temperature decreasing, the pH will go up. So you correct the pH to reach again 7.4 and keep it on 7.4 during the hypothermia and during rewarm or cooling of the patient. This is you follow to keep you follow pH and keep it around 7.4. Regarding the alpha stat, that you not follow the pH. So if pH increase more than 7.4, it shouldn't be corrected because it's physiologically increased due to the temperature change in the blood. So this will give better cerebral or less blood cerebral flow to decrease the cerebral blood flow and keep the cerebral perfusion regulated by auto-regulation. You will not interfere with it. هذا
أوكي
اللي أنا
thank you.
فهمته يعني. إذا في
تمام.
أحد عنده إضافة
سلطان
تفضل دكتور.
السلام عليكم، ازيك؟
عليكم السلام.
أولا شكرا for this presentation. You almost covered most of the points. Just يعني few points to remember in for pulmonary bypass. It's teamwork between the surgeon, anesthesia, and perfusion. Okay, so it's not only the perfusionist. We all have senior perfusionists and well trained, but also you as a surgeon should know what is going on. Okay. The other thing that you should have also a standard protocol. This will help you to overcome any mishap that may happen during the procedure. And you should have good communication between you and your perfusionist. And also you should listen to what the perfusionists say. If the perfusionists tell you that there is low flow or high arterial pressure line, for example, you should listen and look for something that may be going wrong. Don't ignore whatever the perfusionists say. Okay?
Okay.
This is very important. I think بس حاجه ثانيه صغيره في اظن I think في ميستيك بس انت في اللي انت كاتبه في كلمه واحده بس ان الكارديك اوتبوت is 250 مللتر per minute. I think there was كانت غلطه بس مطبعيه بس انك كنت بتكتب. Okay. Yes, and then otherwise it's an excellent presentation. Yeah.
الله يعطيك العافية. Thank you for joining us. في أحد عنده سؤال؟
Any other questions? Okay, thank you, Dr. Sultan. We'll take a break for 10 minutes, then we'll be back, inshallah.
إن شاء الله. الله يعطيك العافية.
Dr. Khalifa, can you prepare your slide, please? تفضل, you can start.
Bismillah. Assalamu alaikum. Today I will speak about cardiopulmonary bypass, pitfall and management. I'm Dr. Khalifa Al-Alazi, cardiac surgery resident. My objective in this talk, it will be a condition which is identifiable before cardiopulmonary bypass, and also condition which is identified at initiation of cardiopulmonary bypass and during maintenance of cardiopulmonary bypass. I will start first with the condition before cardiopulmonary bypass. As we know, some condition can be jeopardize the patient through the cardiopulmonary bypass. These issues which can be identified before we are going to surgery, like atherosclerosis aorta and hematological problem, we have to know, and if the surgery, reoperative surgery. For atherosclerotic aorta, there is a large multi-center study identified the presence of proximal aortic atherosclerosis is the strongest predictor for stroke, and there is a risk factor for that. Significant carotid and abdominal aorta and left main coronary artery atherosclerosis, aortic wall irregularity, and on the ascending aortic angiogram, and adhesion between the ascending aorta and its adventitia, and pale appearance of the ascending aorta, and also minimal bleeding of aortic stab wound. All these risk factors will include in the high risk atherosclerotic aorta. And there is a maneuver intraoperatively which can play a role in identify the atherosclerosis. This one is palpate the aorta by the surgeon, and also while observing that the surgeon can clamp the superior and inferior vena cava for a short time, so that will decrease the arterial pressure, and then he can palpate gently to identify the site of cannulation. And preoperatively angio or CT to be done to assess the smoothness and irregularity of the aorta. And there is another modality which is intraoperative by TEE or sterile AV aortic ultrasound. Can be also done by this ultrasound can be placed directly in the heart, which is more sensitive than TEE to identify the plaque site. In severe disease for atherosclerosis, no such technique we should follow it, and we have to go for femoral or axillary site for cannulation, or sometimes as an alternative, maybe if you couldn't do that, you can go for long arch cannula in the underside of the aorta, or sometimes cannulating the left ventricle, which is weird. I just read it in the book. This is the three types of ascending aorta atherosclerosis, where there no clamp to be applied. The first type is circumferential ascending aorta calcification. You can see it even and observe it through an X-ray, and maybe easy to diagnose. And once palpate the aorta during operation, it will be fair. The type 2, it will be a pattern of can be diagnosed preoperatively by notice the irregularity in the wall. Visualize of the ascending aorta also consider mandatory part of before CABG, especially. And type 3, where there is intraluminal liquid. If you can identify the wall, it's somehow thick, and it will be appear in OR as a pale appearance of aorta with adherent of adventitia to the wall. For the hematological disease, I will, as I mentioned before, I will speak about cryoprotein and hemoglobinopathy and some miscellaneous disease. For the cryoprotein, we have to know the cold agglutinin, which is an antibody forming against and becoming active against an RBC, where once the blood temperature decreases, that will produce agglutinin, and which attach to the RBC and causing hemolysis. Clinical characteristic of this antibody, it has a thermal amplitude, which we have to be tested if it's positive, and the titer, if it's 1 to 32, it will be low, and if it's greater than 1 in 128, it will be high. And as we go in rewarming during cardiopulmonary bypass, during that rewarming, we have to cross to have an enough cold environment where the agglutinin will form, and also enough environment which is warm to activate the complement and to allowing complement fixation. For the clinical sign, maybe include acrocyanosis, which is cyanosis of the digit and the nose and sometimes an ear from agglutinin, and causing ischemia in the end artery, especially. And we have to screen the agglutinin at 4 degrees centigrade Celsius degree. If it's negative, I will go to the scheme which is show that if it's negative, the surgery can be go without any alternative technique. But if the agglutinin test is positive, this is why the patient in the floor, we have to obtain after that thermal amplitude and titer. We have to know how much titer we have of the agglutinin and how much the temperature where the agglutinin is activated. If it's clinically insignificant, which is low titer and low thermal amplitude, you can proceed with the maintaining temperature above thermal amplitude for sure. But if it's clinically significant, very high titer, and we have the balance 1 to 32 and 1 to 128. If it's an elective, that's mean if it's an elective surgery, that's mean this surgery it can be delayed. So and maybe he has some infection there, so we'll wait till 6 weeks. Then after that, once readmitted again, if it's negative, we can proceed for surgery. If it's positive, we have to take the full precaution of agglutinin and hemolysis. But if it's urgent, we have to proceed with precautions. In the patient who's, and we have to consider any patient where we are not screening him as agglutinin within the, we have to be cautious for agglutinin called agglutinin antibody. While we are doing the surgery, we have to observe the vessels. If there is any hemolysis, that will manifested by hemoglobinuria, which is dark urine, and also agglutinin can be seen by, especially while we are wearing loop. If we are concentrating in the vessels, you will find some streak-like thread. This is agglutinin accumulating in the vessels, but this is not in the heart. This is, I think, in the retina. There is two types of agglutinin called agglutinin, monoclonal and polyclonal called agglutinin. The monoclonal, it's associated with mostly neoplasm, lymphocytic neoplasm, which is irreversible. But the polyclonal, it's reversible and transient, sometimes taking some just weeks, and spontaneously remit. This is mostly associated with viral infection. And this acute, the polyclonal, it's an acute situation with life-threatening if it happens, if you activate the polyclonal, and it will cause a hemolysis and in vascular also hemolysis. The treatment, it's to prevent complement activation, and also ultimately to also agglutination, if you could, once you have amplitude, thermal amplitude. In the mild cases, treatment only corticosteroid, it will help. But in severe cases, in acute infection or elective or urgent surgery, as we explained before, that treatment will go with, especially with high amplitude. In elective cases, we have to have, as we said, we should postpone this surgery. But in urgent surgery, there is some precautions. We have to use normothermic or mild hypothermic, and we have to be sure above thermal amplitude. But if it's high, we have to use even warm cardioplegia. But if we couldn't, and we have, let's say, we have to go in cardiac arrest, like or cold cardioplegia, we have to flush a warm cardioplegia first. Then after that, so we can wash the whole RBC in the coronaries, and then by cable cannulation, then we will tighten the cable tapes, also to avoid the cooling of large surface area other than the heart, and then lower the cardiopulmonary bypass flow. Also, we have to have low flow, and this will help in where the blood does not reach non-coronary collateral, and it will not cool and causing agglutination. Also, venting the left ventricle should be will avoid the cooling, so we have to vent the left ventricle. And if we can steroid cardioplegia, it's better than the blood cardioplegia, so we can avoid also agglutinin. And myocardial insolubility, it's to prevent the cooling of blood in shunt, also if it's present. Additional point about that, antibody can be diluted also through the circuit primum solution. this will also decrease the activation of agglutinin. And if we have an event of unexpected agglutination, we have to verify the blood bank and for cold agglutination, and use a crystalloid as we mentioned before, and non-cardioplegic technique, if you could do electrical fibrillation and doing as a rest. Then maintain systemic temperature 28 to 30, don't go lower than 28, and monitor also the bypass pressure at the arterial line. Because sometimes the agglutinin is formed in the arterial line, so we can also use the filter there. For the hematological problem, which can be identified pre-op, we have a sickle cell trait and disease, and also hereditary spherocytosis, and miscellaneous disease as a thalassemia and G6PD and methemoglobinemia. For the sickle cell anemia trait and disease, as we all know, the normal adult hemoglobin, it's containing of hemoglobin A compromise of 96% to 97%, which is having two chain, alpha chain and beta chain, and there is sickle cell hemoglobinopathy, either heterozygous or homozygous. In heterozygous, it's a trait because you have only single gene affected. In homozygous, it will be disease. And but by the way, the heterozygous, it will appear it will occur the hemolysis at 40% saturation. But in homozygous, which is diseased sickle cell, it will occur in 85 saturation. So we have to keep that in mind. There is some provoked condition will causing hemolysis and sickling first, then hemolysis, which is hypoxemia and acidosis. For operative strategy in sickle cell patient, first to prevent sickling and therapy to prevent hemolysis or vaso-occlusive phenomena intra-op and also post-op. That can be achieved by maintaining adequate arterial oxygen tension and also adequate capillary perfusion by maintaining the transient capillary time, and also avoid low output status, where that will decrease the venous mixed saturation, and that will lead to desaturation. And also continuous measurements of ABG and venous mixed venous saturation, arterial hemoglobin saturation, and mixed venous. And the last one, if we couldn't, we can dilute the hemoglobin S, which is in the sickle cell, and it will be predominant in the homozygous diseased sickle cell, and it will be less in trait, up to 20% to 40% maximum. We can dilute the hemoglobin S by hemoglobin A by using preoperative and or intraoperative exchange transfusion. Preoperative, if the patient having anemia, and we have to decrease the hemoglobin S, so we will that will improve the oxygen carrier capacity. So we can do it preoperatively. But if the patient is anemic, we can transfuse or exchange transfusion. We can do it intraoperatively, and that will be our target of hemoglobin A up to 60 to 70% of the hemoglobin. For the acidosis, which also can provoke the hemolysis, sickling and hemolysis, it's mainly concentrated in the shifting of oxyhemoglobin dissociation curve to the right, where increasing the sickling. This is the curve where the oxygen attached or detached, load or unload from the hemoglobin to the tissue, for sure. And arterial and mixed venous blood gases should be measured frequently, because as we mentioned before, there is a certain target we don't want to go at that limit. And to be treated, once we have acidosis, to be treated aggressively with sodium bicarb. And also we have to avoid hypoperfusion, as hypoperfusion will cause desaturation of blood during the capillary and venous phase circulation, and that will decrease the hemoglobin oxygen saturation. Then the blood cell will sickle. This can be prevented by, as we mentioned, maintaining adequate systemic cardiopulmonary bypass flow, and also avoid low cardiac output. You have to maintain flow and avoid cardiac output. For localizing sickling, this sickling can be occur in, let's say, in the heart during aortic cross-clamp. So, because absence of coronary blood flow, and can be avoided that by flushing hemoglobin S by coronary artery during cardioplegia, and preferable cardioplegia, which is crystalloid, or blood with hemoglobin A. Then mechanical blood trauma, which can cause also sickling and hemolysis. We have to avoid in those patients mechanical valve, and also to minimize cardiotomy suction, and also to avoid hypothermia, where hypothermia can cause hypoperfusion, then desaturation and sickling. This is all for sickle cell. And for hereditary spherocytosis, which is an autosomal dominant defect affecting the cell membrane, and once aggravated, the cell wall will be spheric in shape for the RBC, and that will increase the osmotic and mechanical fragility. Treatment for hereditary spherocytosis, as we know before, is splenectomy, but no much information about cardiopulmonary bypass in this area. But there is some report which is a splenectomized patient not appear to increase any blood desaturation or fragility of osmosis during bypass, and previously undergo splenectomy, who's undergo splenectomy also not increasing in hemolysis during bypass. But they mentioned it's better to have short time of cardioplegia, where cardiopulmonary bypass, where that decrease the complication. For miscellaneous disease, thalassemia, glucose 6-phosphate dehydrogenase, and acute methylglobinemia. For the thalassemia, it exhibit no increase in red blood cell fragility, because thalassemia and no hemolysis. But if we have an anemia, we should treat it by transfusion, because this is not a cell membrane defect. Instead, it's a protein defect. And for glucose 6-phosphate dehydrogenase deficiency, it's X-linked inherited, and explosive hemolysis can be occur, but it should be triggered by receiving drug, special drug like anti-malaria. We all know the quinolone and the quinidine, vinacetine, which is analgesic, and sulfonamide. For the acute methemoglobinemia, in this case, there is an increased production of methemoglobin, which is an active hemoglobin, and it's very bounded to the oxygen and cannot be released, the oxygen to the tissue, to the level exceeded 1%, because the normal level is less than 1%, caused by usually poisoning with a drug classified as either direct oxidant or indirect. Direct oxidant as nitrate, nitroglycerin, and sodium nitropyroxide, and also even high dose of methyl blue. High dose, I mean 7 milligram per kg, also can aggravate methemoglobinemia. But by the way, this is the treatment also of that. We can give methyl blue. Diagnosis, we can diagnose that by cyanosis or oxygen desaturation occur in the presence of adequate arterial oxygen tension. So we have a good oxygen, but still there is a saturation, desaturation. And also the blood, it will be chocolate brown, not desaturating dark blood, and can be confirmed by spectrophotometer. For the treatment of acute methemoglobinemia, funding the drug. Just a minute, sorry. Sorry for that. The treatment for funding drug should be withdraw first. Any drug can cause this situation. We have to stop it, and also maximize oxygen concentration. And if all that it's not helping, we can go for pharmacological therapy, which is methylene blue, 1 to 3 milligram per kg, which converting the methemoglobin to an active hemoglobin. If all that failed, we can go also with high dose vitamin C. Then we can go for exchange transfusion. Also, that can be help us. For the reoperative surgery, the presence of problem in the redo cases because of all of that, because of adhesion, and either secondary to sternotomy or to just an access of fissures for cardiopulmonary bypass, all that will be difficult. So necessitating that using sharp dissection, and that tend to bleed and have a higher transfusion rate. Surgeon should dissect as little as possible during that redo cases, and minimize large disrupted tissue surface area. In some cases, cannulation of femoral artery or femoral vein can be done if you have no access to the aorta, and placing an adequate size femoral artery, it will be ease, but the most difficult it's vein. Femoral vein will be difficult to judge. And there is a long thin wall kink resistance femoral vein cannula. Now it's available, and this can be reached up to cavo atrial junction. And the length, because of the length and standard gravity, this will sometimes inadequately permit the full cardiopulmonary bypass. That will maximizing the height of difference in between the patient and the reservoir, and can be repositioned the cannula, sure, but usually no improvement in the venous drainage. So we have to augment the flow in such cases. We have two types, either in centrifugal pump. We can activate the centrifugal pump and the flow placed in the venous line. So that will add the negative pressure while you are pumping, and that increase the venous line flow. But in the venous reservoir, this is the roller pump, may have a regulated vacuum that can be applied to affect additional venous line flow. So we have more negative in the reservoir. And requirement during doing that, we have to carefully monitoring the venous line pressure, and also to avoid emptying or excessive level of the vacuum, because in these two will result in collapse the vascular wall into the venous cannula, and either this way and will block the venous line or venous flow, or intermittent flow or rhythmical jerk sometimes, which also can be increase the hemolysis. This is the before even we start the cardiopulmonary bypass, we have to consider all these. Then once we are initiating the cardiopulmonary bypass, the patency of this is the condition where can be identified during initiation, where we have to ensure the patency of and continuation between the patient and the vascular system, patient vascular system and cardiopulmonary bypass circuit by cannula malposition, kink, any in the tube or clamp, absence of any air bubble in the lines. Then this is the one thing. The other thing, which is presence of abnormal anatomy, let's say like left SVC or aortic regurgitation. Both of them can affecting our strategy. And also if there is anastomotic chance which obscure the surgical site, or requiring placement of, sometimes we are requiring to placement the fint in the pulmonary veins. So the first condition, the acute aortic dissection, it's associated with high mortality, leading to modification. Once it's happened, it can modify the original surgery. Let's say we are going for CABG, then we end up by replacing the ascending aorta or pental if it cannot be repaired. The incidence of ascending aorta cannulation, it's less in if you compare it to the femoral artery in form of dissection. And susceptible patient, especially the patient who is going for CABG and who have atherosclerosis and hypertension. And triad of observational may aid recognition of acute aortic dissection. First one, unexpectedly increased cardiopulmonary bypass arterial line pressure, especially in the first while the perfusionist is testing, will have a high pressure during testing. The second one, coincidence with the profound decrease in systemic pressure, and also decrease venous drainage to the pump or bypass. And at the surgical field, we can see hematoma developed around the cannula, or there is bleeding from the bare string suture. So if we are suspecting, we have to stop the cardiopulmonary bypass and knocking or clamp, then palpate the aorta. If the aorta is flaccid, then we have acute aortic dissection. We have to clamp the venous line and just to avoid withdraw the blood from the patient to the pump, what they call it here, to avoid exsanguination the patient into the cardiopulmonary bypass reservoir. Then the arterial line can be removed and reinserted in different location. Then you have to repair that dissection if you could. The risk decreased if the brisk backflow of blood at the time of insertion of the arterial cannula. Once you are inserted the arterial cannula and the blood is gush in the cannula, this means less likely to have dissection. And also palpate, this is a perfusionist, he has to do it, palpate the pulsatile line in the cardiopulmonary bypass before starting, and also direct continuous measurement of arterial line pressure. You have to have it. And this is can be done by electronic transducer or aneroid gauge. And this is all for the initiation. Then after that, the condition where the occur during maintaining the cardiopulmonary bypass. We are initiating and going in cardiopulmonary bypass, how we can maintain the cardiopulmonary bypass and what's the issue which we have. Either inadequate blood flow or inadequate gas exchange, or sometimes electrical problem, and also air embolism, which we have surgical air embolism or pump air or anesthesia air, and how we treat the air embolism also. The cardiopulmonary bypass depends on two requirements: maintenance of cardiopulmonary bypass, adequate blood flow volume to maintain adequate flow, and also adequate gas flow to maintain appropriate gas exchange. The third requirement is not requirement, it's avoidance of the air embolism in all stages and all procedure. Miscellaneous problem can be happen during maintaining cardiopulmonary bypass, jeopardizing the patient well-being. It's an error in drug administration or contaminated of the circuit or patient, or transfusion reaction and administration mismatch the blood product. All that will affect the blood flow, that will affect the and also gas exchange. In the first parameter, which is inadequate blood flow, first cause, it's an acute aortic dissection, which is we already discussed about. The other causes or mechanism of inadequate blood flow include low circulatory volume, either due to decreased priming volume of cardiopulmonary bypass, or limited pre-cardiopulmonary bypass fluid administered by anesthesia. So anesthesia, he is not giving fluid, and also administration of vasodilation. Hello. And undetected blood leak also, which is having most commonly in the operative field occur due to Swan-Ganz, mostly catheter, especially once we go in hypothermia and the cannula, tip of the cannula is stiffen and become cold. That will injure the pulmonary artery, and so there is a common practice. We have to withdraw it during bypass. We withdraw the Swan-Ganz if we have it 3 to 5 centimeters back, and don't inflate the balloon during hibernization. The other causes is inappropriate cannula size. Also, the size of the cannula compared to the patient. This will also decrease venous drainage. Rare manifestation, it's a venous cannula, venous cannula manufacture defect, where there is a decrease the cross-section area of the lumen. There is an extra material inside the lumen. This will affect the flow also. And partially obstructed arterial cannula or oxygenator, because once the arterial cannula is obstructed, that will increase the cardiopulmonary bypass system flow line pressure. That will increase the pressure before that, but it will be lower the expected patient arterial pressure. After that, it will be low. The blood pressure, the pressure which he will receive it will be low. The last, it's entrained venous line air, where once the venous line is pulled out, that will decrease the cardiopulmonary bypass system, especially in the once the whole venous line is filled with air, that will affect the siphon effect, and will we will lose that because we are depending on gravity to flow the venous line. So we can restore it by slower the cardiopulmonary bypass flow, or clamp it for a while, then refill the venous line. Then you can, once the air go to the vacuum pressure, to the vacuum, then you can walk after that, or you can complete. Then cardiopulmonary bypass sometimes failed, and which is decreased blood flow. If it's centrifugal pump, the magnitude force will be increased, and you will hear a high winging sound while the pump is rotating. And for the flowmetry show no flow. In the roller pump, very difficult to detect, and the flowmetry rarely used in the roller pump. For the inadequate gas exchange, we have physical issues related to the whole body oxygen consumption during bypass. We will not speak about that. We'll speak about mechanical problem related to inadequate gas exchange by the oxygenator, include oxygenator failure, or the gas which is delivered to the pump that's failed. So we can diagnose either by dark colored blood, that means deoxygenated blood, exiting the oxygenator, where should be that blood should be oxygenated, should be containing oxygen, shouldn't be dark. The cause either through loss of gas supplying to the blender or flow meter, or failure of the blender, which is very rare. The clinical related here, patient sometimes lightly anesthetized, so he will require more oxygen, or hypothermic. Also, if he is inadequately muscle relaxation, this is all anesthesia part. And also if it's inadequately anticoagulated, where the clot will be formed if we already started the cardiopulmonary bypass, and the clot will affecting the oxygenator membrane. And for the propofol, which some anesthetic giving the propofol during bypass. This is not recommended, as the propofol is oil based, and that will directly affecting the membrane oxygenator, and that will occlude the port or the pores in the membrane. So the management here, we have to change the oxygenator membrane. Before once was a bubble surface, there was having to stop the cardinal bypass to do this. For electrical problem, which is a common problem but rarely happen, especially rarely affecting the patient adverse patient outcome, because power or electrical failure, especially it will be in the hospital, it will be backup in the emergency generator, and sometimes the cardinal bypass system having its own batteries, some new generation, and also all cardiopulmonary bypass pump, it should be have provision, especially the roller pump. It will be have a provision for manual, hand, and crank if there is no electricity. And there is interesting static charge which is created by the roller pump rotation. This can be interfered with the cardinal bypass, but they prevented that by metal jacketed the oxygenator. And for the perfusionists, they should re-zero the transducer because it may be drift during the bypass. So he should re-zero it before and during also, to have an accurate to have an accurate measurement parameter. For the air embolism, we have air embolism can be occur either from the surgical site in the operation air embolism, or pump air embolism, or anesthetic air embolism, and how we treat that. In the surgical air embolism, there is a report in 1940. First major air embolism happened during cardiac surgery. It was reported by Carroll, and he was saying opening of the ventricle or pulmonary artery and the aorta is always followed by entering the air into the heart. So the air embolism on the left side of the heart, it will be well known to the thoracic surgeon before, as they are explained it in air embolism before. It will be absent in the, if there is an absence of PFO or veins, and the factor of its small injection in the pulmonary vein also. So all that will was examined and observed before. Mechanism of death, because they are doing on animals, especially dog, they are saying one of the mechanism of death, either through the coronary, which having immediate death, or through the cerebral brain damage, with severe brain damage. The outcome, which they show by direct injection of the air, if you are injected in the left atrium, it will be 100% death. If you are injecting in the left ventricle, it will be 80% death. But if you are injecting the aorta or common carotid or descending aorta, it can be tolerated as they reported. But if you are injecting too much, up to 10 ml per kg, this will cause definitely death. they are injecting only 2 ml per kg before. The preference of cannulation of the ascending aorta during cardiopulmonary bypass, you have to optimize the method by direct insertion of the cannula without using side biting clamp, because once we have side biting and we are opening the aorta, that will trap the air and may cause air embolism. Second, it's unexpected resumption of the heart beating. While we are walking, then the heart start to beat. This will create an air embolism. And also inadequate step to remove an air after cardiotomy. After we are closing the heart, we have to do a de-airing. Coronary air embolism with the cardioplegia technique. Sometimes we are delivering the cardioplegia and delivering air embolism through the coronary. So we have to flush it before. And intraventricular air especially with the right superior pulmonary vein venting. Once you have the vent and you are opening the artery, coronary artery, via the coronary artery, by creating negative suction, significant negative suction in the ventricle, that may cause also trapping air from the atmosphere through the coronary to the ventricle. And drawn retrograde through the opening of the coronary artery, if the aortic root vent is there also, would use with significant negative pressure also. The second, it's the pump air. The pump, it can trap air either from arterial line or other mechanism. The arterial line, due to emptying of cardiopulmonary reservoir. Once we have cardiopulmonary reservoir is empty, it shouldn't be empty. If the perfusion, you should look at it always. And also high pump flow in conjunction with the vertical cardiopulmonary bypass reservoir outlet. Outlet of reservoir, it was vertical. This will cause vortex of the air, so it will accumulate the air. So that's why the new manufacturer, they are doing horizontal or angled air column. The roller pump head tube may be ruptured or malfunction, and sometimes then it will be exposed to atmosphere. And the oxygenator or venous or cardiotomy reservoir maybe also become pressurized if the pore for venting to the atmosphere is occluded, so it can suck air and send it to the bloodline. During anesthesia air most commonly occur in intravenous or monitoring line. Fetal air embolism during prolonged procedure, it was being reported. Patient was in sitting position at 1902. This happened with the neurosurgery case. And also the other thing, because they are pushing a little air with each line and with each syringe, and they are underestimate this air. With the prolonged procedure, this air can make a difference. Second thing, it's inappropriate ventilation of the patient during insertion of cardiopulmonary bypass cannula. Once we are inserting the cannula, or even the left atrial monitoring line, while he's expanding the lung fully to it should be to displace the pulmonary vein air. So this is the de-airing. If he is not doing that during cardiopulmonary bypass, this may cause air embolism. 50% of nitrous oxide ventilation, if they are using not intravenous ventilation oxide, that will promote the growth of bubble and that will increase the cerebral ischemia by increasing CSF marker. Especially this is with bubble oxygenator, not with the membrane oxygenator. The advice to avoid it during cardiopulmonary bypass. Shouldn't do this during cardiopulmonary bypass. Treatment of air embolism, either intraoperative or post-operative. I have a table summarizing that. I have a couple of lines, but I can list the management in multiple points. Perfusionist, you have to stop immediately the pump, clamp arterial and venous line, and notify the surgeon and anesthetist, and locate the source. Should be locate the source of the air to pressurize the cardiopulmonary bypass component. So isolate the component from the patient before relieving the pressure, so we can connect the arterial line to the venous line, and he will wash or flow. Then the perfusionist bear the air from the cardiopulmonary bypass system flow line and refill with the fluid. Once we have connecting the arterial and venous. Surgeon, he can aspirate if he has an air embolism. If it's in the arterial cannula, or if it's possible in the, he can do cardiac massage, or he can do retrograde coronary sinus or fainting. This is all can help him. In anesthesia, he can place patient in head down, in the step head down position. Be prepared to temporarily occlude the carotid artery sometimes, but that also may increase the stroke if he has atherosclerosis in the carotid. And confirm sufficient volume in cardiopulmonary bypass reservoir to resume cardiopulmonary bypass, and active aortic root venting. There is a vent which clearing the root to increase the pressure. If suspected of cerebral air embolism, we have to call the patient and institute retrograde cerebral perfusion to packing patient head with the ice, and that will help. And anesthesia can ventilate the lung vigorously with 100% oxygen, and he can give corticosteroid, so he can minimize the inflammatory reaction, and administration of mannitol, and which is diuretic, to maintain for 48 hours post-operatively, because sometimes air can dissolvent and come out. Aim for yearly patient arousal and assessment for return of normal mentation, and consult of neurologist for if there is damage, and consider CT, MRI if patient fail to awake, and consider hyperbaric oxygen treatment, which is a chamber with the hyperbaric oxygen, and almost always the patient will go for this. They can recovery, but it will, even if the treatment is delayed. But this type of chamber will be limited worldwide. And the last one is, but we cannot transport the patient through the air, where that will once we go up, the pressure will go down and the bubble will increase. That will expand the brain damage. And the last one, we have to do resuscitation until the patient either expired or the brain dead. Otherwise, we have to continue to resuscitate him. And thank you. This is all, and this is my reference. Thank you. Any question?
Thank you very much, Dr. Khalifa, for this excellent lecture. I have no comments. Just thank you. You summarized everything that matters regarding this issue.
Thank you.
Dr. Khalifa, السلام عليكم.
السلام عليكم.
Okay, معك. شكرا for your nice presentation.
Thank you.
يعني just few comments. بالنسبة للأورتيك atherosclerosis, it's better always to have a plan ahead before going to the surgery. It
Yes.
helps you much so that you can arrange with your perfusionist and anesthesiologist of what you are going to do exactly. يعني actually our routine يعني doing CT for almost all patients regardless of their age. That it will give you a good idea about presence or absence of calcification.
Yes, Doctor.
تاني حاجة بالنسبة للكابج اللي في حالات الأورتيك atherosclerosis, الكابج I usually go on for total cross clamp. I never use a partial cross clamp for almost 10 years now. And I think it makes a difference, يعني avoiding partial clamping on the aorta. This is for the aortic calcification. Second thing for بالنسبة للredo surgeries, you mentioned about cannulation, يعني femoral cannulation, and you said that sometimes the femoral vein is not enough for venous return.
Yes.
I think now you're right, but now with the presence of smart cannulas, which they are using in minimally invasive surgery, it makes a good difference. And also you can cannulate the internal jugular vein if you need. It will give you a good venous return. And once you open and you get in, you can cannulate the superior vena cava if you still need good venous return. Okay.
Yeah, good strategy.
Last point, just for the aortic dissection, which iatrogenic aortic dissection, which I hope no one sees this complication. It's very, very rare, alhamdulillah. But you have to avoid using force while inserting your cannula. You should dissect the adventitia very properly, because this is the most, this is the strongest layer of the aorta, the adventitia. So you should dissect the adventitia, avoid leaving any adventitia flap. And make a good incision in the aorta, which could pass the cannula easily without using any force. Okay.
Yes, thank you.
I hope, and thank you very much.
No, you had a lot, Doctor. Thank you, and thank you for your presence.
Thank you, Khalifa, for this very extensive review that covers mostly everything. I remember I saw a case when I was a medical student, and the surgeon noticed streaks of like a clot or something, and at that time thought of cold agglutinin, and it was very interesting. However, the patient did well. That's the only case I remember of cold agglutinin. Interesting. Specific rare conditions that and how to deal with it. Thank you.
Yes, thank you.
Thank you, Dr. Khalifa. Any other questions from the floor?
يعطيك العافية خليفة. I just have a question for Dr. Bakir.
Okay.
So this is Lohel Khalaf. So during your cabbages, you will do all the proximals while cross clamp. So
yeah. During cross clamp, no partial clamp.
Okay. Do you think this is a better way for?
I think that's because the partial clamp is more hazardous as regards embolization compared to the cross clamp. And you know my point?
Yeah.
Just avoid the partial clamp as much as you can.
It will add
well, first of all, it gives you, it does not add, it does not, only 5 minutes for each anastomosis. And the other thing, you will find manipulation of the aorta very, very easy while doing it, the proximal anastomosis on the cross clamp. Very easy.
What we are if we confine only for arterial? يعني lima to LAD and vein on the lima to another target.
For total arterial, you mean?
No, lima to LAD, and if we have another target, we'll have a vein to the lima.
Okay, you can put it with cross clamp.
Yeah,
it's no problem. right؟
اوكي.
في حاجة مش واضحة ولا؟
لا بس أنا يعني thank you.
Is there any other practice in the area? Any other consultant around, or chief resident maybe? Or Roy, have you seen different practice?
Well, we don't usually, we do the proximals usually on a partial cross clamp in our hospital. We just do the distals, and then we remove the cross clamp and start in perfusing the heart, and then we do the proximals. That's what we're usually doing. I saw some surgeons do the one that Dr. Bakir mentioned.
That is also the case in PSCC. Some surgeons do their proximal with partial cross clamp, and some just leave the initial cross clamp. My personal opinion that leaving the initial cross clamp is associated with less manipulation of the aorta, and we are not going to basically put another force and crushing more potential lesions. So if we can do the proximals in a reasonable time, why not just leave that cross clamp?
I think it depends also on how bad is the pre-op ejection fraction underlying myocardial pre-op myocardial contractility, and how much you're worried about the ischemic time. That will make you make a decision about whether weighs the benefit and risk in both ways.
But put in mind once you finish the distal and proximal, you remove the clamp, the whole heart is vascularized totally. I mean, so this is another point advantage also.
Okay. Any other comment or question for Khalifa or Dr. Bakir? Okay, so by this we will conclude our session. See you next week, inshallah.